shared notes are the other thing that are essential for the process to work. The team meetings happen weekly, and they're not compulsory.
So shared notes is when you...
Is a software system that we can all log in, and I can see what the doctor's done, I can see what tests, I can see what specialist reports have been ordered, I can see what x-rays the osteopath's requested and what he's working on. So having that full blueprint of the person as they're going through the system and what they're finding is essential. The other one is the team meetings are absolutely essential, and as practitioners, we attend these meetings. We don't get paid to attend them. We attend them because we love them, what we learn from them and how we grow as a body of healers is profound for us. And I've never been able to put it into words what happens in those meetings, but there's some nice research coming out now about the flow. What happens when we come together in those meetings? I think as a group of healers, we hit a flow state very quickly, and we start to access a higher knowing of what this patient needs, because we move out of ego and owning that client, and we move into just for the higher good of that client. And so I realise now we hit a flow state in those meetings, and that's why the practitioners attend them. And that's a pretty nice thing to have happen every week.
Stefan Elber, he's a global health economist, talks about how by the year 2030 our global health services are going to be bankrupt. So if we want our children to have access to health services, we really need to be looking at cost, and the costs are rising exponentially. The other reason is that there is so much evidence out there to show that the current system is not working optimally. There is a raft of additional evidence to show systems that do work well. Most of the evidence that's coming out these days is around continuity of care and the benefits that brings. And, so I just feel that with the evidence that we have and with the fiscal imperative that we have to keep our health services running sustainably, and with the current outcomes that are really so poor given the amount of money that we're spending, we really need to be reassessing how we're running things at the moment.
That was Sally Cusack, New South Wales Branch President of Maternity Choices Australia, Australia's peak national consumer advocacy organisation committed to the advancement of best practice maternity care for all Australian women and their families. A recent study from the Mayo Clinic in the US revealed that 88% of patients were receiving a diagnosis that was either incomplete or incorrect. Out of those receiving an incorrect diagnosis, the Mayo Clinic's findings pointed to physician lack of time and resources as one of the main causes for physicians making these mistakes. With antimicrobial resistance on the rise, largely due to multi-drug overuse, and chronic health costs expected to impact heavily on the system by 2030, we are forced to ask the question, is our disease management-based model of healthcare really working? On the other side of the mirror, there is serious concern as to the toll the current medical operating system is having on the physician's overall well-being. Mental and physical health are at risk when doctors are overworked and receiving very little job satisfaction from treating patients in a fragmented way. In the US, 300 to 400 physicians commit suicide each year, and it is estimated that around 1 million patients lose their doctors to physician suicide each year. In Australia, we are also seeing physician suicide on the rise. Some GPs see up to 30 patients a day, having little to no follow-up as to whether their treatments subscribed have actually helped a patient. The pressure on all healthcare personnel is high. It's easy to want to point the finger at the physicians and healthcare institutions, but where we really need to look is upstream. The causes of why physicians and healthcare teams make mistakes when they don't have the resources, training, and sufficient time when it comes to primary healthcare. The way we need to think about the problem itself is the very way medicine needs to change if it wants to continue to be sustainable and of value in all its sectors. The Australian healthcare system is complex, comprehensive, and one of the best in the world. Most of us have access to the care we need when we need it, most of the time. As evidence-based healthcare is emerging and new ways of interpreting medicine and science are establishing, many Australians, consumers and providers are also inspired to reform their local systems. It is more important to know what person has the disease than which disease the person has. William Osler.
So these kind of like protocols are important, and we're developing integrative medicine protocols, but actually you've got to totally individualise. You can use that as a guide, but you've got to totally individualise the approach for each person. And there's this thing where people think, these are all the factors that play into this state that this person's got into, and we have to address all of them. Well, you don't. Actually, because every kind of disorder or every symptom is multifactorial in terms of its etiology or cause, sometimes you can just tweak a couple of things and the picture starts to change and the trajectory starts to change, and then people feel more motivated and more free to do the next bit. And so that's really the art. I guess we're in integrative medicine for doctors, we're bringing back also the art of healing, because it's not really just, it's not just about the physical. We know that it's not just about one part of one system. It's about fully integrating not only all the systems but the whole being in front of you. And that requires a lot of listening and non-judgmental listening. It requires time. It requires that we love the unlovable in our patient, all the bits that maybe other people don't want to address, that we can sit with them, be with them long enough to understand where the readiness is, where we can start, where that person's ready to move or to shift. And they might not even have a diagnosable disease yet, or there's a lot of diagnosable things now that we don't know how to treat conventionally. So again, it's going back to the basics, which is, how is the body functioning? Where is the body not functioning well, and how do we help, to get it back into a functioning state?
Reversal of type 2 diabetes, it's not even something that was in our zone. Like, it's in kind of our zone integrative, and I'm sure all of you have examples of changing people's diet significantly and seeing their insulin go down, or even getting off insulin. You got Dr. Rangan Chatterjee doing BBC Doctor in the House in the UK and showing people getting off insulin in 30 days, and everyone's like, wow, I didn't know that medicine could do that. To talk about the evolution of medicine, I was sure at the beginning that medicine was going to adapt and evolve, right? That medicine was changing, we were going to see a different type of care, there was a different type of diseases, and medicine was going to adapt. And what I didn't realize, and what I sort of realized halfway between the first and the second summit, is that the systems that were needed for helping acute disease, which the whole medical system had been built around, and the systems needed for chronic disease, which were what were needed, were not going to adapt one into another, because they weren't 20% different. They were like fundamentally opposite. One is reactive. It all starts when something happens. You put the most expensive provider into the line with the patient first, right? Why do you start care with the doctor? Why is it that you go straight to meet the doctor? Because in acute care, you need to have the best diagnostician on the ground straight away to work out what's going on. If someone's had type 2 diabetes for 4 years and wants to reverse it, is that necessary? Maybe not, right? Maybe not to have the diagnosis, because they know what they have, right? They don't need a new diagnosis. They need to facilitate behavior change. So, you start to see that, like, how is this going to happen? And so that's why we started to think about, okay, healthcare from scratch. If we were just going to build healthcare from scratch, what would it look like? And I would argue that same conversation is what's happening with Forward and with Verta and all the things you saw earlier. It's like, if we were going to start from scratch, how would we do it?
Well, I said, look, no one's going to give you permission to do this. That's the thing when I said with the group yesterday. It's like, I'm here, and if my permission's good enough as just some random guy with no medical expertise at all, just saying like, hey, do this, you can do it. But I think, no one's going to give you permission to do it, but it's necessary. And there's a lot of things that have happened in the world where, people have just gone off to do something. They've seen something, they felt, a moral compulsion to really follow that, and then it's ended up changing the world. And this is definitely that. My favorite quote is from Bucky Fuller. It says, you don't create change by fighting the existing reality. To create change, build a new model that makes the existing model obsolete. And where else could that be more obvious than in medicine, where most of the cost of most of the diseases are downstream of the actual dysfunction? Type 2 diabetes doesn't happen overnight. The insulin sensitivity reduces over years, decades, until a point where now you're type 2 diabetic. If we can go upstream and deal with it, early on through content, community coaching, before it ever becomes a dysfunction that has to be treated with, with metformin, then you're in a situation where you are actually building a new system that makes the existing system obsolete. And that's, I think, has to be the goal for medicine, to be sustainable in the medium term.
You have been listening to part 1 of the changing landscape of medicine and around the world, and how Australian physicians and consumers are inspired to ask better questions about our healthcare system. Featuring James Maskell, Dr. Penny Caldicott, Ren Dubois, and Sally Cusack. I'm Annalie Attia. For citations, links, resources, and info about this episode, visit our website, pbbmedia.org. We hope you've enjoyed this week's Pregnancy, Birth and Beyond show, which was produced with the support of the Community Broadcasting Foundation, coming to you from the studios of Bay FM in Byron Bay and broadcasting across Australia on the Community Radio Network. You can find our show on iTunes, Spreaker, the usual social media under Pregnancy, Birth and Beyond, and at our website, pbbmedia.org. Tune in next week for more information and inspiration, bringing us full circle.